All right. Next, we have the privilege of hearing firsthand accounts of transformation, innovation, and success from 3 hospitals that have embraced the journey of improvement. We will hear the journeys of Wellstar MCG, Northside Cherokee, and Fairview Park. A question and answer session will follow the conclusion of 3 lectures. Please hold your questions to the end. And now I'm going to introduce the participants. First, we have Evonne Ivey, is the manager at Women's at Fairview Park Hospital and has the opportunity to work with staff in each department as well as caring for patients during their experience of growing their family. She has worked for Fairview Park for more than 20 years in several different roles, caring for pediatric patients, moms, and newborns. Next, we have Kandy Riner, who's the lactation coordinator at Fairview Park Hospital. She loves having the opportunity to work with families to help establish a good breastfeeding foundation. She's been happily employed at Fairview Park Hospital for over 39 years. During that time, she also provided agency and PRN work at Coliseum Medical Center in Oconee Regional Hospital. Kristin Moses is a graduate of the Florida State University College of Nursing. She spent her entire 16-year nursing career in women's services, starting her nursing career at Northside Atlanta Labor and Delivery. After some travel nursing and 7 years spent in nursing informatics for the women's health population, Kristin has returned to the inpatient setting. She now serves as the Northside Cherokee Maternal Clinical Development Specialist, working towards quality and process improvements for the OB patient population. Carla Allen completed her Bachelor of Science in Nursing at the Medical College of Georgia. She completed her master's degree in nursing management and leadership from Western Governors University. She has 19 years of experience in perinatal and neonatal nursing. She's currently serving as the nurse leader for Pomelo Care, a maternal virtual care platform. She worked in various roles at Wellstar NCG, a regional perinatal center in Augusta, Georgia, for 20 years. Carla previously served as a member of the Wellstar MCG Health Maternal and Infant Outreach team as the data analyst and initiative lead for the Georgia Perinatal Quality Collaborative. Carla has been a member of the Association of Women's Health, Obstetric, and Neonatal Nursing, Evonne, since 2006, serving as Augusta area chapter leader, the secretary-treasurer of the Georgia section, and most recently the Georgia section chair for 2022. She is an alumnus of Evonne's Emerging Leader Program, and Carla is an engaged leader who has a passion for improving collaborative efforts across the continuum of care for improved maternal and neonatal outcomes. Welcome to all of our participants.
Well, good morning. My name is Kandy. I am the lactation consultant at Fairview Park Hospital.
And I'm Evonne Ivey. I'm the manager for women's services at Fairview.
And we're going to show you the first slide, which is our team. And this is our team. And I promised them I'd say their names, so I am. So we have Michelle, we have Callie, we have Dr. Bullen, we have Brittany, we have Evonne, we have Emmy, we have Lindsay, we have me, we have Taylor, we have Brittany, and then we have Sylvia. No, that's not Brittany, that's Brianna, sorry, and then Sylvia. I'm not going to mess up anybody's names. So we know that rooming in is beneficial for all moms, so we chose this as our smart aim for optimizing newborn nutrition.
So our smart aim was to decrease the time that the newborn was in the nursery from 6 hours to 3 hours in a 24-hour period by December of 2023.
So this project is something we have been working on for a while. We knew the babies were in the nursery a lot. We just weren't sure how long and how much time they were spending there. So at the beginning of 2022, we started looking at charts. Not everyone was charting in and out, so it was kind of difficult to get the exact numbers at that time. Next slide. Oh, no. That's not it.
We need to go back?
Yeah. There you go. Slide 4. But looking at some charts, we were able to see why babies were in the nursery and where areas of education was needed. After speaking with some moms and nurses, I realized that some infants were being kept in the nursery longer for the pediatricians to make rounds. I will talk about that a little bit later. I also found out that some nurses were offering to take infants to the nursery so moms could sleep and have rest. So at staff meetings, I would encourage staff to chart times in and out for the babies and encourage rooming in. So then I audited charts through the end of the year, and infants were still in the nursery about 6 hours a day. So looking at the initial audit, we recognized we needed further education for moms, parents, and our staff. So we are not a mother-baby unit. We have a separate nursery with staff, and we have a separate OB unit with staff. All of our staff is cross-trained, and we're able to work both areas, but we knew with this going in, it may pose some challenges for our staff and our parents and our moms.
So our key drivers were, first of all, our SMART aim was to decrease the time of the newborn that was in the nursery from 6 hours to 3 hours in a 24-hour period by December of 2023. Our primary drivers included awareness of benefits of rooming in with mother or the parents, early initiation of breastfeeding or milk expression, unit culture that protects and promotes breastfeeding, and staff confidence and commitment to assistance with breastfeeding. Our secondary drivers were prenatal breastfeeding education that we provided to the OB offices, as well as the prenatal rooming in education also provided to them. Postnatal breastfeeding and rooming in education that we provided to the staff. Standardized feeding regimen and protocol, that was also some nursing education. And then the postnatal breastfeeding and rooming in education that we provided to our parents.
So I researched educational materials from others and came up with these flyers that show what rooming in is and the benefits for the mom and the baby. These were sent to the OB offices, and they placed these in their new mom's packets. This would give them opportunity, the moms, an opportunity, and the family, moms and family, the opportunity to read these and become familiar prior to admission. So while I was discussing rooming in with my colleagues, they suggested more education for moms, parents, and the family. So with input and collaboration from them, we came up with this flyer. Just as a little side note here, their input was very useful and very good because last year we had 14 of our staff that had babies. So they were all new moms. They were all new, we had 14 brand new babies and new moms. So they knew what they were talking about. So when we sit there and had our little group session, we're talking, they suggested that we put the benefits for the baby, because we know there's benefits for mom and for baby. They suggested we made it, because we want it to be short, you know, not a long flyer, something easy to read. So they suggested we just put some of the benefits for baby, because they said, let me tell you, as a new mom, I'm going to look and see, oh, if that's good for my baby, then that's what I want to do. If it's good for me, I mean, I'm going to like it, but if it's good for my baby, that's what I want to see. So that's the reason that you'll just see just have benefits for baby. But they were given benefits for themselves too in other flyers. But that's what's on. So we put these, we laminated this flyer, and we put it on our computer cabinet, and our computer cabinet is right in front of mom's bed. So it's easy for mom to see, and for people when they come in, they can see it too. Okay. Okay, I already did that one. Okay, so we also reinitiated quiet time. And so, I mean, we had done quiet time at one point, and there were some things going on. We had some, I think it was renovations and stuff, and somehow quiet time got put to the side. So we reinitiated quiet time. So quiet time is every day from 2 p.m. to 4 p.m. 4 p.m. we discourage visitors, and we do not enter the patient's room unless they call for us or for necessary care. We do dim all the hall lights, so it's kind of quiet. We do dim all the hall lights, and we minimize the noise at that time. This allows our moms and parents the time to bond with their baby and to rest. So this was approved. We went to our CNO, Pam Manders, and she approved this. This is how we got this done. We went to her, had a meeting, gave her all the benefits, and she said, great idea, go with it. So she gave us the approval, and so we initiated quiet time. So we informed all of the other departments and educated them on what quiet time was so they would know what this process was. Okay. So we place signs strategically to remind visitors and departments of this new process. So this is one of the doors that go into our OB unit, and it, stop, scan your bag, of course you can't go in, but we have the sign right there, and you can't visit. You open the door and you read this sign here. So it does remind visitors that we do have this quiet time during that time. So our marketing department helped us create and put a video on social media educating the public on quiet time. I don't know if we can play the video or not.
It didn't play.
It didn't play?
It's about 1 to 2 minute video. It's on our Instagram page at Fairview Park Hospital. If you want to go,
Played on there. I don't know what happened.
if you want to go look at it.
Yeah, it was just, we got there and just kind of, this is Sylvia, one of our nurses, and she's also a lactation consultant, and she helps me a lot. And we just did a quick little video, put it out there on social media so that everybody could see what we were going to be doing. So when we initiated, when we initiated Quiet Time, it actually coincided with Mother's Day, the week of Mother's Day, because we started this in May of 2023. That's what it was, a year ago, May 2023, we started this Quiet Time. And so because it did coincide with Mother's Day, we kind of capitalized on that. And so we, by doing this, we did a campaign for Mother's Day so everybody would learn what Quiet Time was, what RNC-Ob was, how this was beneficial for mom and baby, had this bonding time. We also had special cookies made up that said mom on them, and we gave those out the first week and to introduce that. And so we just thought that was a nice idea to get everybody involved and let moms and everybody know what Quiet Time was and be prepared for it. Okay, so.
Well, there it goes.
There it goes.
Now, how do we get the volume?
And this is my associate, Sylvia. So we're here to talk to you about Quiet Time. So Quiet Time will be offered to all of our patients here on OB every day from the hours of 2 p.m. to 4 p.m. During this time, we will be discouraging visitors, and also we'll only be entering our patients' rooms for essential patient care. Sylvia is going to tell you some of the benefits of Quiet Time.
So Quiet Time is going to allow baby, mom, dad, significant other time to bond, rest, relax, with decreased foot traffic in their room during this time frame.
So we hope this experience will be positive for you and your family while you're here at Fairview. Thank you.
So just quick and just out there for the public to see. So, and we've had a very positive response to our Quiet Time. Even the nurses like it. I mean, it's a 2-hour mark. 2 hours they get the chance to do some charting and things. But we've had because we asked, like the first week or so that we did Quiet Time, we asked, how did you enjoy it? And one of the daddy goes, I love it. It was the dad. He was the first one to say, I love it. I said, well, I'm glad. Mom, how about you? She says, I did. Yeah, it's great. And dad goes, yeah, we had 2 hours. Nobody bothered us. We was
Hi, I'm
Kandy. We had the
Kandy.
best time. So it has worked out very well. So next thing. So we also recognize that having our pediatricians make rounds to the mom's room with the parents would eliminate the need for the nurses to transport infants to and from the nursery daily. And this would cut down the time the infants were in the nursery. So previously, we would have the babies lined up for the pediatricians to make rounds. And as y'all heard in the very beginning of this, how long I've been working at Fairview Park Hospital, and I've started there when I graduated from nursing school and have been there ever since. So I've been there a long time, so I've seen a lot of changes. So yeah, we would have the babies lined up. We, the pediatricians, were making rounds at about this time, and so they wanted them bam, 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 and then we'd go out. But we know that these pediatricians having the chance to be in the rooms with moms and dads and the parents and whoever's in there gives them the opportunity to do their exam and discuss their care with their infant so that the parents could be a part of that. So our director, Michelle Smith, saw this as an opportunity to increase patient satisfaction. And she spoke with our CMO at that time, who was Dr. Harrison, a great man, Dr. Harrison, and he said, yeah, this is a good idea. Let's do this. Let's move forward with this. So he went to the pediatricians and he informed them that this would be a process that we would do going forward. And so we are. So we purchased these bags. We tried to make it easier. We didn't want to just put it out there. So we purchased these bags and we put all the supplies that they might need in the little bags so they we laughed and said, you're like a real doctor. You have doctor bags. You're going down the hall. And so we're like, yeah. So they have these little bags now. They can go to the room. They do their exams in the rooms. And so they've become accustomed and they're good at that now. But the nurses did help with this process by reminding them, you got to go to the room. So they walk in and go, where's the, oh yeah, you got to go to the room. So it has been a learning curve. It's been a process, but it's been a year now and it's going smoothly. It's great. The parents, everybody enjoys it because they have the opportunity of being able to talk to the pediatricians when they're in there. Now, it did take a little bit, but it happened. So, next slide. So we began distributing education materials in April of 2023. And as you can see, our times did decrease, and it was less than 3 hours. These were just random charts that we did. Myself and some of the staff had help. We did these charts. So there is a little bit of an increase. You can see we're at 2 in then went down, then we increased a little bit up there. But when I didn't look as to why I was just so excited that it was coming down, but we have to take into consideration that male infant circumcised babies sometimes require a little more observation in the nursery, and this is probably where some of this is coming from. So, but we do recognize still that we met our goals, so we were happy with that. Sorry.
So some of our barriers and things that we learned, getting the staff on board and providing the education that they needed to go with the rooming in. Hardwiring our staff to educate mom and the parents on benefits of the rooming in. Educating our physicians on new processes for infant assessments in the mom's room. Purchasing a mobile scale and physician bags with equipment.
So we are still awaiting our arrival of our mobile scale, which will allow our nurses to do their daily weights in the room, which will cut down even more of our time in and out. So our biggest hurdle, we thought our biggest hurdle of moving forward with rooming in was fear of pushback. But we realized that educating all staff, and having everyone doing and saying the same things, that our moms, parents, and families were well educated, was and still is the key to our successful rooming in. That's right.
All right, our acknowledgement, we want to thank Michelle Smith, our director at Fairview. She was instrumental in obtaining necessary equipment and encouraging the physicians, the nurses, the hospital staff in the implementation of the rooming in process, as well as our marketing department, who has put together the videos and helped us promote it in our community.
Thank y'all.
All right, good morning, everyone. Thank you for giving me the time to speak today, and just want to also say happy Friday. And I have no disclosures to reveal. I will say that, oh, things got a little wonky there. I will say that my role, I'm here representing Northside as a system today, and my role as a clinical development specialist or a CDS, I do a lot of data analysis and performance improvement on the data that I collect for the maternal patient population, just to give you a little bit of a background there. So these are our objectives, and we're just gonna kind of review the evolution and treatment of our maternal patients for severe hypertension. So this has kind of been almost a 10-year process as we kind of go back in the next few slides. So per ACOG guidelines, we all know severe hypertension is defined as a systolic blood pressure greater than or equal to 160 or diastolic greater than or equal to 110, sustained for 15 minutes. So I think that took a while to ingrain that into our nursing staff, just the initial severe range with the repeat and basically that official confirmation of this is what's going on with the patient. So our ultimate goal is to treat the patient with the ACOG-approved antihypertensives in no more than 60 minutes or an hour following that initial severe blood pressure elevation. So from the time of that very first blood pressure, right? So ultimately the result is repeat treatment as necessary until we're able to lower that blood pressure for the patient. So we understand now more than ever our patients are sicker and sicker. It seems we are dealing with treatment of severe hypertension pretty much daily, right? Like we're seeing it all the time. Our patients have more comorbidities, and from a lot of the conversations yesterday, we understand that those cardiac indications are some of the highest indicators of morbidity and mortality. So a lot of what we'll talk about is what we've implemented as a system as a whole, but we're representing what Northside Cherokee has done specifically to promote these measures. So back in 2014, our team initiated obstetric antihypertensive regimens that were made available in OB-specific order sets. So I'll break down what that looks like a little bit more. We made those medications available to order within our women's-specific order sets, right? So they weren't separated out as antihypertensive order sets, but they were made available. And a lot of these changes happened as we were converging to different EMR systems. So then in 2018, as we were transitioning to Cerner, we specifically developed those OB antihypertensive order sets, again, per the ACOG recommendations. Initially, we were going based off of the 4 primary regimens at the time, so IV labetalol, IV hydralazine, PO labetalol, and PO nifedipine. So they were available for order entry at the time of severe range blood pressure. So you can kind of understand that if a patient has that severe range blood pressure, there's going to be sort of a time lapse, right? You have to, A, recognize it first, and then communicate with the provider, and go from there to get those orders initiated. So that's going to take a little bit of time right there. So just keep that in mind as you kind of see the evolution of where we are today. So with that, we started with a significant amount of staff education with the initial implementation of the antihypertensive regimens. So full staff education for all labor and delivery staff and our family-centered care nursing staff. So we call our postpartum units family-centered care. So a lot of what our education was based on was computer-based learning. That's typically our method for system-wide education, as well as staff meetings and leadership meetings. And then our ED staff and our ICU staff received very similar education catered to their units as well, just to have a full understanding of what that treatment looks like. So then in 2021, the team collaborated to further enhance our workflow. And I think this was really key to the success of the process as far as where we stand today. So again, the goal is that no patient would fall through the cracks of treatment, and still keeping in mind that goal of treatment within 1 hour or less. So there was an update made to all of our admission order sets to basically include a communication order giving the nurse protocol to treat for severe hypertension if the scenario occurs. So for example, our antepartum order set would include an option for the provider to select on admission, and it would give them, at that point in time, we're down to the 3 regimens, so IV labetalol, IV hydralazine, and then PO nifedipine. It would give them the option to choose, right? And if they didn't want to choose one, it was actually already going to be pre-selected for them. So they could change it if they wanted to, but that then made it available for the nursing staff already to then go initiate those orders if the patient did have severe range blood pressure. So this is the model that we are now using today. So hydralazine was selected as the defaulted regimen for our antepartum, interpartum, and postpartum order sets initially. And that was due to some of the contraindications with the other medications involved. So with labetalol, we have the contraindications for patients with active asthma or history of asthma, and then heart disease or congestive heart failure. So that was kind of the obvious choice, and then again, the provider could choose to select a different regimen if they wanted to. So with these protocols, this is kind of the workflow of what the process looks like. So if severe range blood pressure occurs, the nurse will review the orders. So if the patient's in labor, those are the orders she'll have. If she's antepartum, so on. Reviewing those admission orders, that have been initiated by the provider, and then enter the order for the appropriate antihypertensive regimen in that instance of severe range blood pressure. So they're doing that by protocol, and they're initiating that order set. And then the rationale is that they should go ahead and treat the event, right? And then they're going to notify the provider after the fact, right? They already have that order. Again, we don't want to delay treatment. So the providers will address a new order with each new order set or new phase of care. So if a patient is transitioning from antepartum to labor or then labor to postpartum, they're reassessing, what's going to be best at this time. Do they have IV access? What's the patient scenario? Maybe they've already been treated for severe hypertension and they want to stick with an IV regimen. So they'll evaluate with each new phase of care. So as workflows continue to evolve, we identified opportunities for the postpartum patient, default the PO nifedipine regimen in case IV access was not currently available. So that's kind of where we stand as of right now. And then the hydralazine regimen remains the default for antepartum and intrapartum for that patient population. Again, providers do have the option to select an alternative regimen, and the ultimate goal is to not delay treatment. So this is just kind of a visual that we have provided our nursing staff along with the order sets to give a breakdown of what the details are in those orders, right? So it includes the treatment plan as well as the scenario for subsequent blood pressure elevation if they've already been treated, as well as what the stabilization parameters looks like. So at Northside Cherokee, our goal has always been to recognize our nursing staff who are able to successfully recognize the scenario, right? So I think that's been the biggest hurdle, is recognizing the scenario, and then treating within 1 hour. So we have a variety of different campaigns and intentions at Northside Cherokee specifically. Our first one being the Heroes for Zero campaign. So that's an initiative specifically at Northside Cherokee where we have different clinical goals where we have, hopefully 0 fallouts. That is the ultimate goal. And then also our former CDS, Jamie Lutchell, she's in the audience over there. She initiated what's called a slam dunk, so we'll review that here shortly. And then we're also doing certificates of recognition and some incentives. And in the last few years, we also do SMART goals for each department and each role as well. We've included our severe hypertension as part of our SMART goals for clinical excellence at the department levels. So that goes for both L&D and postpartum. So I'm going to talk a little bit more about our Heroes for Zero campaign. It's a project improvement program to help frontline staff deliver high-quality patient care. It was developed in 2019, again, specifically at Northside Cherokee. And it's to improve the provision of high-quality patient care through an increased awareness and understanding of how performance improvement activities impact our patient outcomes. So it includes all inpatient units in the hospital. And each department selects 2 clinical measures to include as part of their initiative, and as well as two measures, as well as the occurrence of patient falls. And so we advertise this data as part of our performance improvement boards across the units, just so that everybody's aware of where we stand for the quarter. This is kind of the logo for our Heroes for Zero there. So again, early recognition and treatment of severe hypertension for the women's services areas quickly became a staple These measures are reported as part of our department performance improvement data, and we share this information quarterly, again, on our performance improvement boards. And back in 2020, L&D received Most Improved Award in first quarter 2020, and then FCC received that same award in second quarter 2020. So this measure has been our biggest improvement to date at Northside Cherokee for the women's services. So in addition to Here is for Zero, again, we develop SMART goals based on our fiscal year, and it's broken down into individual departments and individual staff member role, again, for performance improvement opportunities. So we identify, where can we improve, and then we set concrete goals and measurements to be able to attain those improvements. So the data that we collect for GaPQC, which we submit on a monthly basis, I take that data and I then break it down at a department level. So when I do that, I do consider different fallouts, right? So the fallouts include, did treatment take greater than 1 hour? If so, what was the scenario going on? Was there documentation to back up that delay to kind of paint the picture of what was going on? Another fallout includes the failure to even recognize and treat when that severe hypertension is sustained. So that's going to be a situation that's going to require some re-education potentially, maybe one-on-one with that staff member. And then failure to repeat the blood pressure per policy. So with that, we're looking at a 10 to 20 minute window for that repeat if we do have an initial blood pressure in severe range. And again, if that's a failure, then we always strive for one-on-one re-education in those scenarios. So there are specific scenarios and considerations that we may consider a throwout or exclusions, basically meaning at the department level, not for our GaPQC data, but at the department level and for our SMART goals, they may not be counted against us based on certain factors that may be out of our control, right? So some of those might be the RN was able to document why was the blood pressure not repeated, right, within that expected time frame. Maybe the patient got up to the bathroom and the nurse actually wrote a note, blood pressure not within expected time frame, reassessment now, or whatever the note might be. It gives me a point of reference so that I know the nurse understands what the expectations are, right? Another exclusion would be if the MD or the provider chose not to treat when clinically indicated based on that nurse to provider communication, or and that would be a scenario where the patient didn't already have those admission orders in that protocol order. Otherwise, the nurse would have gone ahead and treated in that situation. And then another exclusion would be those erroneous blood pressures requiring repositioning of the blood pressure cuff, or patient is actively getting an epidural as evidenced in documentation. Another one that we've seen recently is going back to the MD choosing not to treat, specifically is, the patient was up and walking around, she's been on the phone, we'll give her a little bit more time, right? So it's scenarios like that where maybe that blood pressure is just kind of brushed off, and we as nurses are not able to treat as we would like to based on our policy, right? So based on all of that, I do a lot of digging in these charts, right? So I'm looking for any information I can to kind of, again, paint the picture and explain the different scenarios of what was the nurse thinking, did they communicate with the provider, and where did we land? So early on, one of our one of our initial recognitions that Jamie actually started was called the Slam Dunk Award. So each month as we analyze the hypertension data, we are going to recognize all nurses who appropriately treated within that 1 hour time frame. And they received a little certificate as well as a Dunkaroo snack. So that's probably gonna be a throwback for any of you 90s kids or parents of 90s kids, if you remember. Yeah, I see some hands in the back. If you remember those Dunkaroo snacks. So they were given that as well as the certificate. I don't think you can read that in the top corner, but that's what the certificate read. You contributed to a success for our Heroes for Zero initiative by accurately recognizing and treating severe hypertension last month. Great job. Thank you for your dedication to our patients. So they would receive this in front of their peers, and I think that's kind of what was most important, was that they actually did a survey to kind of understand how does staff like to be recognized, right? You know, some people don't like to be recognized in front of others, but resoundingly in this situation, they said that they do like to be recognized and they want to be recognized in front of their peers. So that was always something that was given to them in front of their peers so that their coworkers could, you know, kind of give them another pat on the back on top of their little treat. So some of the other recognition that we're doing current state are certificates, very similar to the previous ones. I have a picture of that here shortly. We are constantly discussing this measure, right? It's a daily conversation for us in huddles, staff meetings, leadership meetings. We do WIGS meetings every week, and this is in the forefront of our tongues all the time, just kind of where we stand. We also talk about it in our monthly meetings with our OB groups, sharing our data, and just, you know, even talking about the hurdles that we have, right? Just to kind of level set and help them understand where we can still improve. And then we also do, again, staff recognition amongst peers. So we share that information on our staff meetings, and we've actually gotten into some additional incentives for proper treatment that I think is going over pretty well with the staff. So again, they've already told us they like to be recognized, you know, let it be known and recognized amongst their peers. It's not a secret, so we definitely give them as much praise as we can for that. So this is what the current certificate looks like that they receive. When they receive one of these certificates, again, this is on a monthly basis, they can keep these and bring it to their evaluation on an annual basis. And it goes towards a portion of their SMART goals, towards that personal, professional element. So that gives them extra points as well. And then we were also featured in the GaPQC newsletter. This was the July 2023 quarterly edition, and this is our staff back in what looks like 2022 during the holidays. So we felt honored to be part of, and still are honored to be part of the GaPQC initiative, especially as it relates to severe hypertension. And you can see those girls are, they're holding their Dunkaroo snack that they received, so. So ongoing education opportunities. So this is where we stand today, and this is what takes place when we have those opportunities for improvement. So the first thing we do is we focus on staff re-education, right? Does does everybody understand what severe hypertension is and how we recognize it? And then from there, we want to make sure the staff understands what's stated in the orders and in the policy, and what's expected with the repeat blood pressure and treatment, right? So again, the ultimate goal is that we're treating with a selected regimen within 1 hour, and then we're going to notify the provider. So we don't have a lot of those delays that we had in our sort of initial version of this, because those orders are already available to us, right? All the nurse has to do is recognize the severe range blood pressure, and then they have that protocol order already in their admission order set, so then they just go initiate the hypertension plan with the regimen that's already been selected by the provider. So that really does eliminate a lot of the back and forth and the conversations that might take place, and then they're having that conversation after treatment, okay? So in those scenarios that do require re-education, so we're going to review the scenario at hand. I've already told you that I kind of review those scenarios in detail by scouring the chart. So we kind of break down what was the issue, right? Did they fail to repeat the blood pressure? Using the orders that were already available, did they fail to treat? And did they maybe treat, but it was greater than an hour? So we kind of break that down. So while I cannot share any data, unfortunately, after showing you kind of the evolution of everything, I can truly attest to a significant improvement in our treatment, recognition and treatment as a system at Northside, but most especially at Northside Cherokee. We've really come a long way with this. We're very, very proud of where we stand today. And I'll just kind of attest to that based on the fact that just last week, one of our departments received a pizza party because their recognition and treatment was so spot on for the last 6 months that they're just so deserving. And again, we've really come a long way, and just very, very proud of our nursing staff for this. And so we'll just talk about next steps a little bit. So we're always striving towards improvement, and any updates that we can do to improve our patient safety is what we're going to do. So coming soon, we have some adjustments to our regimens, specifically the hydralazine protocol. Again, we continue to meet with our OB groups on a monthly basis, just to talk about those opportunities and share our data and where we stand. We are also bringing to Northside Cherokee very, very soon the maternal heart health clinic. So that will include specific referral criteria for those patients who need to be seen post-delivery as an outpatient. And then we also do collaborate with, at Northside Cherokee specifically, we have bi-monthly meetings where we collaborate with our ED to kind of discuss different scenarios to help each other better understand the differences in the scenarios as far as gestational age and treatment, and just that overall goal for more expedited treatment and care of the patient. Let's see. So I think that's it. I just had some notes, but I think that is it. We'll go over questions at the end, so thank you.
Good morning, everybody. I am Carla Allen. I am currently working as the nurse lead at Pomelo Care, which is a virtual medical practice that focuses on maternal health. We are actually partnered with AmeriGroup Georgia. For anybody who has AmeriGroup that's one of your patients, they can access our services, and we have dietitians, mental health professionals, and 24/7 access to care for triage and those kind of things. So I am presenting today on behalf of my former role at Wellstar MCG, where I worked for 20 years. I do want to disclose that this is a shared presentation for myself and the cardio OB navigator there, Tasha Charles, who, if you have not had an opportunity to meet, you definitely need to connect with her. We could not do the cardio OB program there without her and the things that she is doing, but she was not able to be here today. So I want to make sure that we know what we have for her. So the objectives are, we're just going to review the practices that we did at Wellstar MCG, formerly Augusta University Medical Center, to implement our cardio obstetrics program, and how we have worked to partner with different people throughout, not just cardiology, but also our partners with population health, as well as our virtual care at home program to help benefit all of our patients. Back before cardio OB was even a thought for the state of Georgia, really, before that was implemented, one of the first things that we did at MCG was we implemented an obstetrical emergency department. We did that at the beginning of FY19 through collaborative efforts with our obstetricians and our maternal fetal medicine specialist. We created an environment where we transitioned our labor and delivery triage, where it wasn't first come, first serve, where we did a lot of maternal fetal triage index education for all of our staff. We formalized a staff that was just nurses who were focused on triage when they were there. So it wasn't, I had a labor patient who's actively laboring, but oh wait, it's my turn to get somebody. One of the things that, as we were implementing this with our medical director, that was very, very important to us is that we expanded care beyond just that. We initially started, of course, with 20 weeks of pregnancy, but unlike our partners around our region, we stopped not seeing postpartum patients until they were very, very sick. We opened up our obstetrical emergency department to see women in that postpartum period until they were 6 weeks so that we could capture severe range hypertension. It was one of our first goals, our first wins of implementing that, and it was something that both Dr. Ray and I were very passionate about to make sure that we did, because what we were finding is our ER colleagues were sending women home who had severe range hypertension untreated, or they would keep them there for hours and then realize, oh wait, we should have sent them to labor and delivery to start magnesium therapy. So with OBED, it was one of the first steps in this process of that early recognition and improving patient outcomes and care. And to date, they've seen over 2,000 women in that. We started seeing in that first period, we would see somewhere between 5 and 7 postpartum patients a month. And that has, again, significantly increased, primarily because we're doing lots of education around signs and symptoms at time of discharge. So the program development, I like to share these two fellows. If you guys don't know Dr. Chad Ray, he, former president of GOGS, is there at MCG, has been a staple there since his residency. But the unicorn in this picture that you guys may not know is Dr. Gyan Sharma. Dr. Sharma is one of our cardiologists. He is the head of the cardio obstetrics program in the cardiovascular division. He also is the head of imaging. He actually approached Dr. Ray as they both were kind of thinking about this as an idea and a concept and said, we need to partner to better take care of women. I would tell you that his colleagues in cardiovascular services, primarily because my last role at MCG was as the administrator for cardiovascular services, so I learned more about it, were very reticent to take care of women who were pregnant. I know as we started talking about this and rolling out this program in my dealings with Evonne and talking with my nursing colleagues, the biggest barrier was finding a cardiologist who was remotely interested in helping take care of pregnant women. Pregnant women scare people. They scare people in the emergency department. They scare people that are cardiologists. Unless you were trained in obstetrics, you do not want to deal with a pregnant woman most of the time. So with these two guys, we came up with a plan before it was formalized as an objective for the state of Georgia, so we were excited to be a part of that. This is a small part of our team. Since January, we have also added a pediatric cardiologist who can see our pregnant moms who are 18 years or less. We have also added a heart failure specialist, Dr. Evonne Riner, who will see these women because, again, we all saw presentations yesterday where this isn't just about what's happening in their pregnancy. This is about what's happening to them postpartum and beyond. These are about women that we need to follow for that entire first year and likely beyond. One of the things that Tasha and I did last year was we went out to one of our outreach hospitals. They asked us to come speak for Red Women, the Red Dress Day. And a lot of the women there were older. They were outside of childbearing years. And I asked the question, this probably doesn't seem relevant to you all because you're not having babies, and we're talking about cardio-obstetrics. How many of you had toxemia? Hands went up because there were some older generations. I said, okay, for folks my age, how many of you had preeclampsia? Some hands went up to include my own. I said, did you know you were at risk for cardiovascular disease? Are you seeing a preventative cardiologist? Have you had any care since your pregnancy? Because when I started obstetrics, the cure for preeclampsia was delivery of your placenta. So, and until I started this program, I didn't realize that outside of my strong family history of cardiovascular disease, that the fact that I had preeclampsia put me at an increased risk. So the beautiful part about this photograph is that this is growing every single day. I know that Tasha and Meredith's our nurse practitioner who's partnered with our cardio-obstetrics program, presented to GaPQC just a month or so ago. So we have gradually grown the program from a half-day clinic once a month to we are seeing folks once a week for a full day of clinic. We have echo spots that are specifically designed for these cardio-OB patients to coincide with their physician visit. That way, they don't have to figure out how to come. Yesterday, we talked about childcare. We talk about transportation. One of the things that I've learned in my new role at Pomelo is a huge part of why women don't access care is they can't focus on access to their own care and their own healthcare needs until we address the things that are those social determinants of health. Unless we can help them keep their lights on, keep food, get transportation, we will never, ever be able to move these metrics. We have to focus a lot on those social determinants of health. And by adding folks on, doing telemedicine, doing some of the things that they're doing there at MCG, we're seeing an evolution in the program. So the way the program is involved, of course, we talked about in FY22 how Dr. Ray and Dr. Sharma sort of got this idea together. The cool thing about Tasha Charles, for those of you that are interested, is that she's not an OB nurse. Tasha Charles is Dr. Sharma's cardiology nurse. And Dr. Ray and I interviewed a couple candidates for this position after I transitioned to my role in cardiology, and I told him, I said, she has a passion for women, and she already knows cardiology. In this role, you need somebody who knows cardiology and is passionate about women, and if you partner them with the right people in obstetrics, you can teach them the obstetrical pieces. It's harder to do it the other way. Just for some growth opportunities, in FY22, they saw 67 patients. To date, Tasha sent me new numbers that go all the way through April. They have referred 343 people just so far in FY24 to the cardio-obstetrics program. Now, of those appointments scheduled, 97 of them were no-shows. They are attributed to, I didn't have a ride, I couldn't break away from work. The same things we're all talking about, and how can we make that care a little bit easier for our patients. One of the things that they've done is partner with population health in order to get patients monitored remotely as well as virtual care. So the virtual care at home program, Tasha also happened to be already involved in that a little bit. She did some PRN work during COVID there and has just kind of kept on. We had a unique opportunity to partner with them there at MCG as well as with their rural emergency medicine providers so we can get education out to our rural emergency medicine colleagues, as well as using the virtual care at home platform to take care of women in the postpartum period. This is how we have worked to meet that 3-day metric to get people followed. And these folks at virtual care at home start following them postpartum day 1 after discharge. They get blood pressures, they follow up on symptoms, they have very specific algorithms to make sure if they need to be referred back to the hospital, they can be, but for the most part, they're being managed there at home, and we're not holding appointments in the office that people may or may not show up for, because as we all know, in those immediate postpartum days, it's really, really hard for women to get back for appointments. These are just some virtual care at home numbers. Thus far in 24, we have had 13 people enrolled. Tasha has referred over 40 people, as well as our residents, to the virtual care at home program. And so we are seeing that. We've seen a little bit of increase in our readmits and ED visits, but it's because we are catching these women after discharge while they're still at home for things that they wouldn't have necessarily reported back for themselves. Again, we have a co-grant with our population health folks for maternal care. They are doing a VITA RPM program, so remote patient monitoring. Dr. Marlo Vernon is working with her team and growing that program. They are in phase 2, and they have just enrolled their 89th person according to their nurse educator lead for that program. They do not only screening of blood pressures, but they also do education for blood pressures, weight management, mental health resource screening, as well as diabetes screening. They offer resources for housing and food and transportation, clothing, diapers. That is the goal of our population health partnership. So again, helping to meet those SDOH needs so that we can get women better cardiovascular care and just better care for themselves overall. Some of the strengths of the program include expertise of our faculty. Again, we have combined our superpowers in that we have cardiology and obstetrics, as well as experts in virtual care partnered together to provide this. Unique regional program for cardiology and obstetric partnerships. We are the first in our region to offer this and want to continue to do outreach as the regional center. Collaboration across multiple service lines is noted, and then early adoption of the AIM metrics and protocols to help us improve care. And then, of course, continuing education programs. And not only are we doing it through residency education at our own facility, but getting it to OB conferences for nurses, OB conferences for providers. The Georgia ACC conference, they had 2 presentations. At the ACC National Conference, they had presentations. And then also, we have recently presented at the Georgia Rural Emergency Medicine Conference in Savannah. So again, those emergency providers, since 70% of our state has counties without a delivery provider, we need those emergency medicine providers to know what to do and to recognize it. And then some of the opportunities and barriers that we've had, our full integration of the CCC bundle for monitoring patients' delivery status within a year in our emergency department, that they need to do more than just ask, what was your last menstrual period? They need to ask, have you had a baby in the last year? And for clarity, my best friend is the emergency department manager at MCG. I tried everything I knew how to do to get them to change that one question on that database. And then their education department opportunities, of course, for ED faculty and nursing staff. And then the current thing that MCG is really waiting on is the Epic build. As they merge with Wellstar, they're going from a Cerner platform to Epic and changing anything in Cerner over the last year while we were awaiting the partnership. And now that transition till October to get it integrated. But our residents do a great job, our attendings do a great job of using the tools that were provided and created as an assessment. Tasha actually goes to daily rounds. Tasha follows up with anybody who risk out. And then I think, and one of our residents is here in the room, I think that Tasha hounded them so much at first and went and spent time in their resident room with them, just parked herself in there with them and helped do the education, because sometimes that's what you need. She made sure that they have resources readily in front of them that is a constant reminder of getting women into these programs. And then inconsistent referrals from our referral facilities. As a regional perinatal center, of course, we want to get women into this program. One of the things, again, that I think is the beauty of having a cardiology nurse and somebody on your outreach team to go talk to obstetrician offices is it makes it very clear that we're not trying to steal their patients. Because I don't know about any of you, but one of the things that we always saw as the RPC is They didn't want to refer patients because we were going to keep them. We will send you these people back to deliver. We just want to take care of their heart, and you are not the expert to do that. So next steps, going live with the risk assessment, of course. They are starting a food to medicine program, which is super exciting. Again, having a food pharmacy there available at the hospital on campus so women can have access to fresh fruits, fresh vegetables, those better nutritional value foods. Utilization of a mobile care van, which is in the development, and then, of course, regional outreach to OB providers as well as family medicine practices. Our outreach educators also focus on those non-delivering hospitals as well as some of our partnerships with Georgia Rural Emergency Medicine. So we're excited to be able to continue to do education. I'm excited to still be a part of it, even though I am no longer with the facility, and continue with the work that I'm doing with Pomelo to help monitor patients and give care to women across the state. So thank you all for having me.